Okay, so today we're going to talk about interface dermatitis, and this corresponds to chapter 7 of the Elston textbook. So, first, when you hear interface dermatitis, that can mean either lichenoid or vacuolar dermatitis. Those are the two main subdivisions. So, lichenoid basically means it looks like lichen planus. And then it's further subdivided based on if there's eosinophils present or parakeratosis. And then vacuolar, that one's further subdivided kind of based on how much inflammation is there and how many lymphocytes are present. So we'll get into more specifics as we go. So for our first one here, we have a band-like lymphocytic infiltrate at the dermal epidermal junction, and it's destroying the basal cell layer here. And we see a lot of apoptotic keratinocytes, which are called Savant bodies or colloid bodies. We see some pigment incontinence. Um, and then we see some sawtoothing of the reedy ridges here. So this is our prototypical lichen planus, and sometimes people see these spaces here and wonder if that's a blister, but that's artifact in this case. So it's called a Max Joseph space. So lichen planus, you see lichenoid band-like lymphocytic infiltrate. There's not usually parakeratosis or eosinophils, but it may be present in certain subtypes of lichen planus. And then you see the wedge-shaped hypergranulosis too. So here there might be like a little increased granular cell layer. Um, and then you see a regular thickening of the epidermis. And then if you did a diff, you would see shaggy fibrinogen along the basement membrane, and then the colloid bodies stain with IgM mainly, but also IgA, IgG, and C3. And most of those apoptotic keratinocytes are in the basal cell layer, but some fall down into the superficial dermis. So a little bit about the clinical. It can be triggered by a lot of different things, including hepatitis C, certain medications, depression, anxiety, and there's a lot of different genetic factors involved as well. So these are the purple pruritic polygonal papules, and they're frequently on like your volar wrists, but also can be oral mucosa can be involved, shins, other areas. There's a lot of different clinical variants as well. And it's important to know that there's an increased risk for SCC with the hypertrophic oral and vulvovaginal subtypes. Okay, next one. So this one looks similar. You have that lymphocytic infiltrate at the DJ, but you have some perikeratosis here. And you can see in the dermis here, there are some scattered eosinophils present. So this one is lichenoid drug eruption. So it looks like lichen planus, but there are eosinophils and there is parakeratosis. And these patients tend to be older and the rash is more generalized and it can even look more eczematous or psoriasiform. So this typically starts 12 months after starting the medication. So it can be really hard to pinpoint what drug it is. But common culprits are ACE inhibitors, beta blockers, NSAIDs, allopurinol, and more. Okay, this one is kind of tricky without clinical context, but it looks like lichen planus, but it is probably arising in a solar lentigo or actinic keratosis or SK. So this is a benign lichenoid keratosis. So basically, this is a lichenoid dermatitis, but it's just one specific spot, and usually it comes in as like rule out basal cell carcinoma because it just presents as like a pink papule. And usually there's not eosinophils. So this is due to inflammation of a lentigo, SK, or AK usually. And the diff looks similar to LP as well. Okay, next one. So again, we have a lymphocytic infiltrate, but it's a little bit more sparse. We have a lot of pigment incontinence. We have those apoptotic keratinocytes, and overall it looks a little sclerotic possibly. So this is lichenoid graft versus host disease. And this one also may have parakeratosis or eosinophils. And this is more of like a chronic graft versus host, which is after the first 100 days after stem cell transplant, versus acute is in the first 100 days. And this has a little bit more of like vacuolar interface, necrotic keratinocytes, some abnormal epithelium. So, like I said, this is a complication of stem cell transplant, but it can also happen with blood transfusion or solid organ transplant. And the most important predictor is HLA compatibility. And skin is the most commonly affected organ in graft versus host disease. Okay. So, next one. So, here we have some pretty dense inflammation, both at the DJ with some pigment incontinence and then also along hair follicles. This also might be like a little bit of follicular plugging here. And it can be hard to say, but there might be some use in there too. So this is hypertrophic lupus. So you have lichenoid infiltrate, and then it's superficial and deep as well, and you have follicular plugging. The diff would show the lupus band, which is a granular band of IgG, IgA, IgM, and C3, pretty much everything at the basement membrane zone. And you have a lot of plasmacytoid dendritic cells present as well. So, yeah, lupus, main things to remember, a lichenoid infiltrate, but then also a superficial and deep infiltrate and follicular plugging. Okay, so this one, again, is a lichenoid infiltrate. But you also have these atypical larger lymphocytes forming little collections in the epidermis. And that's kind of what's happening at the DEJ as well. So this is mycosis fungoides. So sorry, I said lichenoid, but it's really more vacuolar. Um, and that's because it's less of a band-like infiltrate and more like vacuolization of the basal cell layer. And it's these atypical lymphocytes, like I said. And they kind of line up along the DEJ and then they form little small aggregates. Um, and then those are called petromicroabscesses when they're in the epidermis itself. Okay, next one. So again, we see some interface changes here with some red blood cell extravasation and then maybe also a little spongiosis in the epidermis with some apoptotic keratinocytes. So this is pleva. So you get a vacuolar interface dermatitis with a lymphocyte in nearly every vacuole, so like a lot of inflammation there. You get red blood cell extravasation. You can get neutrophils around dermal blood vessels, and then you can also get some neutrophil crust. Um, and you might see ulceration as well. So clinically, these present as pink papules on the buttocks, trunk, and proximal extremities that crust over and then they heal with variola-form scars. Okay, and this is kind of the cousin of that, where again you have vacuolar interface dermatitis with lymphocytes, not as many red blood cells, not as much inflammation overall. So this is PLC. Um, So again, you get vacuolar interface, mild parakeratosis, but no eosinophils. So it's like pleba, but a little milder. And clinically, it's red-brown scaly papules and plaques that resolve with hypopigmentation, and it tends to last longer than pleva, and it's more likely in adults. Okay, so here we have vacuolar interface and a lot of inflammation, and it's around this hair follicle too. And there's some follicular plugging here. So this is lupus. So the other one was hypertrophic lupus. This one is just other kinds of lupus. Um, so it can be vacuolar or lichenoid. Hypertrophic is more likely to be lichenoid. So this one has compact hyperkeratosis, follicular plugging, basement membrane zone thickening, which you can highlight with a PAS stain. You can see pigment incontinence, which is hard to see here, but like maybe there. um, and some down here. And then other things that you can see mucin between collagen bundles, um, and then lymphoid aggregates within the eccrine coil. And then the dip is going to be that lupus band again. Okay, so this one is in our papillary dermal edema differential, and we have some parakeratosis and lymphocytic infiltrate. So when you see a lot of papillary dermal edema, you should think of a couple different things. You should think of sweets, but you would see more neutrophils with that. You can think of pernio, but that would probably be on acral skin. You can think of bullous tinea, but you would see that you would see organisms in the epi or in the stratum corneum with that, and you can think of PMLE. So this is PMLE, which is a reaction to the sun, and you have papillary dermal edema with a dense perivascular lymphoid infiltrate. Okay, so this one we definitely have. I would probably say this one's more of like a lichenoid type interface here with a lot of inflammation. And then the inflammation is also involving the eccrine coil. And there's some spongiosis going on in the epidermis here too. So this is lichen striatus. So this is a lichenoid interface dermatitis with then perivascular and perieccrine inflammation as well. And a lot of the kids have atopic dermatitis that get this, and it just self-resolves. Okay, so this one, there's a lot of mucin here in the dermis that you can see, and you could highlight that with the colloidal iron stain. And then the interface dermatitis here is very subtle, like maybe a little bit here. And you have some parakeratosis. The epidermis looks like it might be a little thinner here too. So this is dermatomyositis. So this one you get a vacuolar interface dermatitis and some epidermal atrophy with dermal mucin. And it looks similar to lupus, but might have less inflammation, but it kind of depends on what type of lupus it is. Okay, this one. So this one is, there's some lichenoid going on here, but there's also a little psoriasiform going on too. And there's a lot of plasma cells around, and that can be kind of hard to pick up on at this power, but like here's some that you can tell are plasma cells, and that one's a plasma cell. Here's a good plasma cell with that eccentric nucleus. So this is syphilis. And syphilis is vacuolar or lichenoid interface dermatitis with psoriasiform as well. So it has those long, slender, radi ridges. And you have a lot of a lot of plasma cells, but that can only be seen in 2/3 of cases, so it might not always be present. And you can have neutrophils in the stratum corneum. And you can use special stains to identify the spirochetes too. Okay, this one, you have a lichenoid infiltrate here, and some of the epidermis is necrotic, but you still have some that's normal. This is not the best quality image. So this is erythema multiforme. So you have normal stratum corneum, and then you have vacuolar interface dermatitis with necrotic keratinocytes, and it's at all layers of the epidermis, so not just at the basal layer. And then you can eventually get confluent epidermal necrosis. And compared to SJS, there's more dermal inflammation and less epidermal necrosis. So see how there's a good amount of inflammation here in the dermis, and there's still some keratinocytes that have not undergone necrosis yet. So that's how you can tell the difference. And this is most commonly caused by infection. So HSV is number one, and then mycoplasma. And you get these targetoid lesions frequently on the face and distal extremities. And the difference between EM minor and EM major is that EM major has a lot of mucosal involvement, specifically oral mucosa, and then fevers and arthralgias as well. Okay, this one, however, has full thickness epidermal necrosis and a normal stratum corneum. So this one would be your SJS-TEN. So it looks like EM, but more eosinophils and less dermal inflammation, which is hard to tell here because you don't see the dermis. Um, and so remember that less than 10% body surface area is SJS, greater than 30% body surface area is TEN, and 10 to 30% is that overlap syndrome. And this is almost always drug induced. Most common ones, I think, are anticonvulsants, antibiotics like Bactrim, and NSAIDs. And it occurs 5 to 28 days after taking the medication or starting the medication. Okay. And then this is a scoring system that we use in the hospital to determine mortality rate based on different factors that are present. Okay. This one again has a lot of eosinophils, but you have this interface dermatitis here. So when you see eosinophils and lichenoid, you or vacuolar, you should think fixed drug. Um, and this can look a lot of different ways, but a lot of times there's eosinophils and neutrophils and normal stratum corneum. And you might see dermal melanophages as well, which you do see, like this is a melanophage. Um, and then clinically, it looks like there can be non-pigmented forms, but usually it's a well-demarcated violaceous plaque, and it might have a central bulla or erosion, and it can commonly involve the oral and genital mucosa as well. And this is usually caused by antibiotics or NSAIDs, but it can be other things as well. And it usually resolves over 1 to 2 weeks with hyperpigmentation, and the treatment is really just like stopping the medication. And you can do patch testing within a site of prior involvement to confirm that it was that medication. Okay, this one is a little tricky. We see vacuolar interface dermatitis, and then we see these what they call dead red apoptotic keratinocytes. So this is Still's disease. So this is probably more of a chronic lesion. So you have keratin whorls in the stratum corneum and dyskeratonic keratinocytes throughout the epidermis with focal interface dermatitis versus acute would be more perivascular neutrophilic infiltrate. Okay, last one of my favorites. So between a couple reedy ridges here, here's two reedy ridges, you have this ball of lymphocytes and some lymphocytic interface dermatitis, same thing over here. So this is lichen. So they call this like the ball and claw because the reedy ridges sometimes like claw around the ball of the inflammatory nodule. And it's really between like two or three reedy ridges, and it's mixed infiltrate. So lymphocytes, histiocytes, giant cells. And it can be seen in children or young adults as just pinpoint little papules, frequently on the genitalia, lower abdomen, dorsal hands, and it can resolve spontaneously. And that is it. Thank you.